Hello and good evening, everyone. Welcome to the Iron Talks Sunday sessions. On these live webinars that we conduct every Sunday 9 p.m. We've been covering a lot of different topics where we've touched topics such as anemia and assessment, anemia and diabetes, anemia and metabolic syndrome, anemia and kidney disease, anemia and the heart. And today, the topic that we're going to cover is equally important: anemia and pregnancy. So, before we kick off today's session, let me introduce your host for the night, Dr. Sanjay Kalra. Dr. Sanjay Kalra is a DM endocrinologist who's done his DM endocrinology from AIMS, New Delhi. Dr. Sanjay Kalra is a past president for Endocrine Society of India. He is the president-elect for South Asian Federation of Endocrine Societies. Dr. Sanjay Kalra has been the board member for International Society of Endocrinology. He is the president for Indian Professional Association of Transgender Health. Not just that, Dr. Sanjay Kalra has been entitled with a lot of achievements and accolades. Dr. Sanjay Kalra serves on the Research Society for Research Society of Study of Diabetes in India, RSSDI. He has over 1,000 PubMed indexed articles to his name and has fostered bilateral and multilateral links between various Afro-Asian countries in the field of endocrinology. Dr. Sanjay Kalra has developed the terms glucochronology and lipochronology and the glucocopper tool to assess coping mechanisms. He is the winner of 2009 DAWN Dawn Award. He has contributed as an executive editor from 2011 to 2015, where he worked to establish IJEM, Indian Journal of Endocrinology and Metabolism. Dr. Sanjay Kalra, welcome to today's session, and we are pleased to have your presence.
Thank you, Karan, and welcome everybody who is logged in today from India and beyond. It's a great being with each other, and this topic, Iron Talks, is something that is very important, something very close to my heart as well. A question for everybody: what is the atomic number of iron? When we look at that number, we'll see it's a very special number, and it will also tell us why we just cannot live without iron. So, good evening to all the doctors who have logged in: Dr. Dharmaraj, Dr. Sanjeev Puri, Dr. Balu Vayal. So many people logged in. Our topic for today is iron and pregnancy. And for this, allow me to introduce our guest for today, Dr. Bharti Kalra. Dr. Bharti is a gynecologist practicing in Karnal in Haryana. She is the current president of the Karnal Obstetrics and Gynae Society. She is not only a gynecologist, she is also a certified diabetologist and a fellow in sexual medicine, perhaps the only gynecologist with an approved degree in both gynecology and sexual medicine. She has been ex-editor of the Journal of Medical Nutrition and Nutraceuticals. So today we'll be speaking about this nutraceutical. And she's also certified in obesity management. So feel free to shoot your questions regarding obesity and anemia. With her publications, her research record, I'm sure she'll be a perfect fit for today's talk. So Dr. Bharti, warm welcome. Our topic for today is iron and pregnancy. But just a question before you begin your talk. Does iron impact only pregnancy, or does it impact every phase of life for a woman, for a girl?
Good evening, dear friends. Welcome to Iron Talks, especially on the topic in iron in pregnancy. As today we have the topic of iron in pregnancy, anemia in pregnancy, but the iron is needed for each and every phase of life, maybe for an embryo and maybe till our death time. So requirement changes with the age and with the time of life phase. So during pregnancy, the requirement is increased. That is why we are very much concerned, and we are specially keeping this topic for today's talk, that is iron requirement in pregnancy or anemia in pregnancy, mainly related to iron deficiency. Please share the slides. So today we are talking about the anemia in pregnancy. So this is the most common medical disorder in pregnancy, especially in India, where 40 to 75% of women are suffering from anemia during their pregnancy. And in developed countries, only 18 to 20% pregnant women are anemic. And it's not just anemia, but its impact is very large. it impacts the maternal and fetal mortality across the world. So significant impact is there. That is why we have to be very watchful about the hemoglobin level in a pregnant woman. So as per the WHO definition, the anemia in pregnancy is labeled as if hemoglobin levels are less than 11 gram per deciliter or hematocrit is less than 33%. But as per CDC guidelines, the anemia is labeled as if hemoglobin levels are less than 11 gram percent during first and third trimester, and during second trimester of pregnancy if it is less than 10.5 grams percent. So what if we see any hemogram report, what are the cutoff values in which we label any woman who is carrying pregnancy as anemic? If her hemoglobin is less than 11 grams or hematocrit is less than 30%. And if we check her ferritin levels, the lower limit is 12 microgram per liter. And usually if we get the serum iron levels done, if TIBC is 15%, that is the limit for it. So if it is still it is lower limit, and if the requirement is more, so that its level will change. So all these values, if we find in any hemocrit report, we should look for anemia, and especially in iron deficiency anemia. It's not only iron deficiency during pregnancy, there are other causes of anemia also. So in women's first visit, we should rule out all other causes, just like thalassemia. So we should get her HPLC level done in first visit only to clear her whether she is carrying any thalassemia trait or not. So if all other causes are ruled out, then we should look for the iron deficiency anemia. So hemoglobin level is less than 11, that is anemia, but there are severity levels also have been described by ICMR. If it is 10 to 10.9, it is labeled as mild, 7 to 10 is moderate, and less than 7 is severe. And if hemoglobin level is less than 4 grams or decompensation is there, that is the very severe anemia. So all these levels are important to remember because the management changes with the level of hemoglobin level. So just going about physiology of anemia in pregnancy, because during pregnancy the blood volume increases and especially the plasma volume increases more than the RBC count, disproportionately increases there. So because of this dilution, hemoglobin level decreases. So this is the cycle of the RBC cycle, and which shows the anemia can occur in pregnancy routinely. The iron requirement increases during pregnancy because of physiological decrease in hemoglobin levels during pregnancy. Usually, if no supplementation is done, hemoglobin level decreases by 2 gram percent during the whole of pregnancy. So if a woman's hemoglobin level is more than 13 gram percent, so even if it falls, if she doesn't take extra supplements, if level falls, it will come to 11. So that will still be in range. But if someone starts her pregnancy at 11 grams, she will end up with the 9 grams hemoglobin. So that is why that is very important. We have to give the iron supplements. So total requirement is 1500 milligram of iron during pregnancy. Of this, the 400 to 500 milligram is needed for maternal hemoglobin rise and 300 to 400 milligram for fetus and placenta. Fetus draws most of the iron levels from mother during her third trimester of pregnancy. And insensible losses, roughly 250 milligrams of iron levels are lost throughout the pregnancy. And at delivery, normal blood loss is there, in which the hemoglobin serum iron levels decrease by 200 milligram. And it's not just during pregnancy, but during lactation also, supplementation of iron is very, very important. As per her daily needs of percurial blood loss, she needs additional 1 milligram per day for her lactation. So what are the causes why we are concerned about anemia during pregnancy? Because the predisposing factors are there. There is inadequate dietary iron, folate, vitamin B12 intake, and bioavailability of major factors which contribute to maternal anemia. These are very much prevalent. So in obstetric or gynecological causes which are specific to a woman or any girl, because there is a campaign that 12 by 12. That means hemoglobin of any girl should be more than 12 grams of percent at the age of 12 years. So if the hemoglobin levels are maintained at pubertal age, if these are maintained till adulthood during pregnancy, there are less chances of getting anemia. But otherwise, if there is history of menorrhagia, miscarriage, fibroids, multiple pregnancies, or there is teenage pregnancy, means by the time she should attain her adulthood, before that if she becomes pregnant, there are chances that she will be anemic. Or in general, if she is carrying any infection, maybe recurrent UTI, or she is getting parasitic infections, malaria, schistosomiasis, or she is having gastritis, repeated gastritis, maybe because of Helicobacter pylori, or she has bleeding from the other side, sometimes peptic ulcer or hemorrhoids. Hemorrhoids are also very common during pregnancy because of pressure of the developing fetus. So sometimes anemia is because of blood loss while passing stools. And the symptom may be presenting as, if she has iron deficiency anemia, she may present with the pica. Means she has habit of eating maybe chalk or maybe the raw rice or anything which is usually not eaten. Means pica is there. So that is a symptom of getting iron deficiency anemia. Or if she is purely vegetarian and very choosy about her diet and takes less of iron rich diet. So, as discussed earlier, the iron needs during pregnancy, during first trimester, it need doesn't increase much because there is the some iron is stored because of absence of menses. But in second and third trimester, because of volume increase and baby drawing most of the iron from the mother, in second and third trimester requirement increases. So we supplement iron in second and third trimester. So it's not only iron, but requirement of folate is also there during pregnancy. So all iron preparations are made folate as a supplement during that preparation only. So no iron preparation is without folic acid. So we have to supplement it along with the iron that helps building the RBCs. So normal level of folic acid that can't prevent the megaloblastic changes in bone marrow in roughly 25% of women. And folic acid deficiency exists, especially in twin pregnancy or those who are on anticonvulsant therapy during pregnancy. So, and if she is having sickle cell anemia, malaria, or any other cause of hemolytic anemia, so in those cases, we have to supplement folic acid in a higher dose. So, in general, for prophylaxis of anemia during pregnancy, means iron deficiency anemia, the supplementation should be like 16 milligram for iron and 400 microgram of folic acid in routine, especially 100 days during pregnancy. That is a minimum target which should be supplemented. So what are the effects of anemia on mother? If we see, almost all the complications of pregnancy are seen in anemic mothers. Maybe during pregnancy, maybe her symptoms of lethargy during pregnancy, or occurrence of repeated infections, or during delivery, she is unable to push the baby or unable to tolerate the labor pains, or maternal exhaustion is commonly seen in anemic mother, or her cardiovascular changes occur at the time of labor or in late third trimester. So all these things may occur, and after delivery, she may end up in PPH or deep vein thrombosis. And it's not only physical, it affects the mental or psychological level also. So they are more prone to get puerperal psychosis or cognitive abnormalities. So that may be because of she has less of energy because of anemia. She is unable to cope up with the stress of delivery and the puerperal phase, and she gets the psychological problems. So what are the effects of anemia on the fetus? As mother is affected, if she is unable to provide the raw material or the nutrients to the fetus, so there are chances the baby will be in IUGR or may land up in IUD or may have fetal anemia. Maternal anemia may lead to fetal anemia and complications because of that. Or if everything is normal at birth, baby may be having low Apgar store. Risks of increased perinatal mortality or infant death is also increased with this. So we have to be very watchful and for the patient as well as for the developing fetus during anemic mother especially. So there is a very beautiful article of the rubric karma, so which indicates the maternal anemia leads to IUGR. As we see, the Abhimanyu, he learned during intrauterine life and that knowledge was passed into the next generation. Means in embryonic life, what he learned, he showed its effect on extrauterine life while going for the that Mahabharata war, and whatever he learned. So similarly, if mother is anemic, she passes the same quality of blood or same quality of nutrients to the baby, and which may later on affect the infant's growth in infant phase, early childhood, late childhood, or even in adulthood. That effect is seen. So that is the rubric karma. So that is the intergenerational effect of maternal anemia. It's not related to only anemia. It can be seen in GDM also. So these two things are show intergenerational effects. So we have to be very watchful during pregnancy for anemia, blood hemoglobin levels, blood glucose levels, blood pressure, and weight gain during pregnancy, because all these affect the outcome of pregnancy. So how to manage? In Indian population, it makes sense to supplement iron and hemopoietic factors so that the hemoglobin level remains in normal range. So if we supplement uh, prophylactically, we are able to maintain the hemoglobin levels in the normal range as per the trimester wise. So, but how can we attain it? First of all, first and foremost is the dietary advice. So nutritional supplements can be given. That is the first of all what she does in her day-to-day life, and adding upon it iron and folic acid supplementation if her hemoglobin level is in up to the mild anemic range. But if that enters the moderate range, that means if it is uh, less than 10 and up to the 7, and she is unable to tolerate oral iron, we have to think of injectable iron. And if the condition doesn't permit the supplementing iron therapy, then we may need at certain stages of pregnancy and at the time of delivery supportive blood transfusion. So we will go about each stepwise. So about the nutritional supplements, here in our area, most of the pregnant women, they follow the vegetarian diet. So in them, we can suggest them the go for the cereals, especially bajra and ragi in their diets. They can look for the legumes, lentils, peas, chickpeas. Soybean is also a very good source of iron. Green leafy vegetable, nuts, oil seeds, and iron fortified foods. We don't recommend that they should go for the processed food just like Kellogg's iron supplemented. So the other, they can increase their iron levels in their food by adding iron rich, means if they are eating potato and methi, that is fenugreek, they can add, which is a rich source of iron. So if they add, even in their chapatis, if they add fenugreek or palak, so these things increase their iron levels in their diet. uh, in general, if any fruit or vegetable, when left cut open, if that becomes dark in color, if that becomes black, just like in fruit we see the banana as well as we see the apple, they become dark colored. So to the layman, we can tell them if any vegetable or fruit when cut, if becomes dark in color, that is rich in iron, and they should consume that more. So that is a OPD practice. So if those who are willing to take non-vegetarian diet, they should include fish twice a week in their diet. And if they can take beef or organ meat, so beef liver contains 14.8 milligram per 100 gram of meat. So these are the rich sources of iron. So if we have to supplement iron orally, how much requirement is there? For prophylaxis, WHO recommends 60 milligram of iron with 40 microgram of folic acid till term. And Ministry of Health and Family Welfare, they recommend 100 milligram of iron with 500 microgram of folic acid, at least for 6 months. And if we have to treat anemia, then according to WHO, the dose is doubled for iron. Folic acid remains the same, and it should be continued. The prophylactic dose should be continued during postpartum if her hemoglobin levels are normal, and that should be for 3 months. But practically, we follow MOHFW guidelines. We supplement for prophylaxis 100 milligram of iron, and for treatment, the 2 tablets, means the double dose is given for the treatment purposes, and during postpartum period, we give iron and folic acid supplements for 6 months, not 3 months. Is when she is giving exclusive breastfeeding. So that is the same, and deworming is must. It should be done for all, preferably all pregnant women, because junk food and outside food is very much prevalent, so chances of worms are there. So for prophylaxis of anemia, we should give deworming. We should do deworming to all, and mebendazole twice a day for 3 days. That is enough during pregnancy, and that is safe and recommended. For oral iron therapy, different salt preparations are there. We have seen so many preparations in the market that we get confused which should be given, or what we have given, whether the patient is able to tolerate it or not. We go stepwise about it. The oldest one is the ferrous sulfate, then came the ferrous fumarate. These are most widely used and preferred over the ferric iron preparations as recommended by the WHO. So different preparations have a different percentage of elemental iron, and bioavailability is different. So ferrous sulfate has GI side. The iron preparations in which the percentage absorption is less, they have more GI side effects because the iron salt left in gut is means the proportion is more, and those preparations who are with the nanoparticles, the absorption is almost 100%. So they are, the newer preparations are with the minimum GI side effects. So just like the modified release preparations are not recommended because they can be given for prophylaxis, but for treatment purposes they may not be that effective because of slow release. And iron chelate preparations are iron ferrous bisglycinate, glycine sulfate, ferridate, and iron polymaltose complex, carbonyl iron. These are the other preparations. So conventional preparations, their absorption is reduced if they are taken with phytate. Polyphenol means if we take iron tablet with tea, or if we take it with milk, or if we take it with phytate, or the older preparations, if we taken with the calcium, these are not absorbed. The absorption decreases, so effect is also reduced. So this is already described. The GI side effects are more with the conventional or older preparations. So what are the reasons for failure in response to therapy? It is in general for everyone, but during pregnancy, it's more important because this is the time-bound condition that is of maximum for 9 months. And of this, the later 6 months are iron preparations are given. If patient doesn't take it, at term we find patient with anemia. So, what can be the causes for this? What is a number one is a non-compliance. Sometimes patient says, I don't like the taste. I don't like the aftertaste. I get belching with this. I don't feel like taking it because of its size or because of its smell or because of its shape. So many tantrum we can find, or so many reasons we can find for non-compliance. Or sometimes they say doctor has told us if someone gets diarrhea, if we tell them to stop iron for 3 days, they stop it forever and ever. And they say doctor had told us to stop it. So we have to be very vigilant about it, and we have to ask proactively. Or if there is concomitant folic acid deficiency or continuous blood loss is there, coexisting infections, faulty absorption, or there may be inaccurate diagnosis of iron deficiency anemia. Means if she is carrying megaloblastic anemia and we are treating her for iron deficiency anemia, in those cases we don't get response. And if there are other causes of microcytic hypochromic anemia, that is the thalassemia. So in our belt, especially in North India, we find it very commonly, and we have to treat it accordingly. We can't treat them with supplementing iron again and again. So we have to tell them treatment specific for thalassemia trait person. So for if oral iron is not tolerated, or if oral iron's compliance is very poor, or if the hemoglobin level is very low and she is not responding, in those cases we prefer parenteral iron therapy. So if if there are contraindications to, if later in pregnancy there are contraindications to blood transfusion, and we have some time, maybe 4 to 6 weeks, during which time we can increase her hemoglobin levels with the parenteral iron. In those cases we can give. And if there is patient has contraindications to oral iron therapy, so its main advantage is that we can give it with certainty. If we have given the full dose of after calculating her iron hemoglobin level, if we give her full dose, so then we are relieved that till delivery she will having her hemoglobin level more than 11 grams percent, and she will not have complications of anemia. And rise of hemoglobin is similar to oral iron, and up to 1 gram per week can be seen with the parenteral iron therapies. So different preparations are there. Iron dextran is the older one, iron sorbitol citrate, but commonly used ones are the iron sorbitol citrate IM injections can be given if patient is not willing to take IV, or if she has to take it at home, or we can give iron sucrose complex, which is the preparation. We will discuss it later. In iron gluconate that can be given in injectable form. So there are different type of preparations. Some have a thermodynamic property, means strong complexes are formed. That means they release, if we give the loading dose, they release iron in blood slowly. So side effects are less, but the HB rise is there. Minimum sittings are required. Means we can get just one sitting of full dose of iron, and her hemoglobin will rise automatically. Or those preparations which have moderate bonding, means those who release free iron at a higher level, in that we have to give low dose injections, but repeated doses are required for that. So coming to the iron sucrose, which is commonly used in government as well as private sector. In Haryana, it is freely available in government setup. So if we see, if at PHC level, if they do any pregnant ladies hemoglobin, if it is less than 7 gram percent, they refer her to CHC, and where she gets a full dose of iron therapy in repeated sittings. So there is, what are the advantages for iron sucrose? There are no tissue peroxidation, less oxidative and parenchymal tissue injury, and higher availability of iron for erythropoiesis. Minimum side effects are there, but there is a risk of anaphylactic reactions as compared to the newer preparation. And HB rises as early as can be seen in 5 days. So in government setup, this is free, but in private setup is also, it's not that costly. It's also reasonable priced. So, but the disadvantage of multiple infusions, multiple visits, long duration of therapy, because its free iron levels are high, so we have to transfuse it slowly, and because there is risk of anaphylaxis, so that has to be given in hospital setting, where the arrangement for anaphylaxis management is there. So the newer preparations, which are ferric carboxymaltose, commonly known as FCM, iron isomaltose preparation, or ferromoxetol. So this has a unique strong complex structure, releases free iron slowly, and that is why it can be given at higher doses in shorter period. So just quickly going about it, because of its stability, we can give in higher doses, but cost factor is there. As compared to the sucrose preparation, it is very much higher. That may be 100 times higher than the sucrose preparation. So how to administer? If we are discussing about the FCM preparation, if we have to give 100, your requirement is only 100 to 200 milligram of iron, that is just 2 to 4 ml is given. So that can be given slowly. Direct bolus is given slowly. Undiluted form it can be given. But if requirement is more than 4 ml, means up to 10 ml, or 20 ml if we need to give it, means up to 500 milligram. In 10 ml it is 500 milligram, and in 20 ml it is 1 gram preparation. So 1 gram is the maximum dose for FCM. So that should be given in 15 minutes in diluted form. So in 100 ml NS it is diluted and given over 15 minutes. So that is because usually we give it in 15 minutes, and then we wait for 15 to 30 minutes to watch for any adverse reaction. So if we give iron preparation, even oral or intramuscular or intravenous preparations, but there are conditions in which we can't increase her hemoglobin level with iron injections. Maybe it is iron deficiency anemia, or otherwise she has acute blood loss. In those conditions, we need to give blood transfusion for the rapid rise of hemoglobin. So in antepartum phase, if she is severely anemic, her hemoglobin is less than 5 gram, which we see that may or may not increase with the injectable iron. There are chances that it will take longer time. Usually we give around 6 gram hemoglobin level is there. So at that we give Fcm injection or sucrose injection. But if less than 5, it's preferable to give blood transfusion so as to build up her hemoglobin level. But if hemoglobin is 5 to 7 grams, but she has features of impending heart failure, in those conditions we may need blood transfusion during pregnancy less than 34 weeks. But after 34 weeks, because there is very short time interval for the delivery to happen, so she may get decompensation during her delivery process. In those cases, even if her hemoglobin is less than 7 gram, we will prefer blood transfusion, or if she has severe anemia with decompensation, or if her hemoglobin is less, because that is not because of hematinic deficiency, means we find commonly we see in thalassemia trait patients in which the hemoglobin suddenly drops to 6 or 7 gram near term. In those cases, there is no role of iron therapy. We will give blood transfusion. Or if she has acute hemorrhage, maybe APH or maybe PPH, postpartum hemorrhage, in those conditions, we will give blood transfusion. And the postpartum, if she is having shock or acute hemorrhage, and even it is not there, if postpartum hemoglobin is less than 7 gram, in those cases also we should consider blood transfusion. But sometimes patient refuse for blood transfusion, they agree for iron injections. So in those cases, before discharging the patient, we give them IV iron. So what does guidelines say? Different guidelines have different recommendations. So what are the GCP guidelines 2016? We go about it. The MOHFU, they recommend 100 milligram of iron with the 500 microgram of folic acid for 100 days after the first trimester, because during first trimester there is very much increased risk of nausea, vomiting. Sometimes if they take just one tablet, they have taken, and when they start vomiting, they blame it that I had taken one tablet of iron, because of that I am getting nausea, vomiting, and it's not getting controlled. So otherwise also it's preferable to start it from second trimester onwards, because in first trimester the requirement is not much. So the FIGO guidelines also recommend the minimum requirement is 30 milligram of elemental iron, that is for supplementation. And ACOG and UK guidelines also, these guidelines suggest that we shouldn't go for the sustained release or anti-narcotic preparations, because these are less effective. And WHO recommends 30 to 60 milligram of iron with the 400 microgram of folic acid preparations. So these are the guidelines. So in India, we follow MOFHU guidelines, and in which in government setup also they give from fourth month onwards, they give 60 milligram of iron with 400 microgram of folic acid to all the women at least for 100 days. And in private setup also, we monitor their hemoglobin levels and supplement according to their needs. Thank you.
Thank you, Dr. Bharti. Excellent talk. Very comprehensive, very simple. And you've made such a difficult topic appear so simple for us. Lots of comments coming in, lots of questions as well. And there is one question about first trimester. Of course, you had answered it. But why is it that routinely we do not give iron in first trimester?
The otherwise requirement of iron is not there in first trimester as per obstetric point of view, because the fetus does not demand iron at that stage. And because of the pregnancy is because demand is less, and she gets some iron levels because of she has stopped menstruating at that time. The loss she was getting earlier because of menstruation, so that is preserved. That is sufficient to take care of her first trimester phase.
So we start iron in the second trimester. This question and comment has come from many people, including Dr. Dharmaraj. But one of the question is, supposing in first trimester patient comes to me, Dr. Billy is asking, and she has severe anemia, hemoglobin is less than 7, then what should I do?
So because we have to look for if it is less than 7, if she is decompensated or not. If there is feature of decompensation at any level of hemoglobin, then we may need to give her blood transfusion. So if she is unable to cope up, even with if she has chronic anemia of 7 grams, she will not be decompensated with that because her body is able to maintain that level. So if needed in late first trimester, we can start her with the syrup iron, because in with the syrup preparations, just like syrup Vitcofol, we can adjust the dosage. She can start with a 1/4 teaspoon, half teaspoon. If she tolerates it well, we can increase it to 1 teaspoon or maximum 2 teaspoons per day.
So that is a good idea, actually, good clinical tip for us.
And
Syrups will
nutritional
help,
supplement is to be given.
and you focus on nutrition. Dr. Ashutosh Das says, uh, is it correct to give iron to everyone in pregnancy, even without testing, or everyone in lactation?
See, in India, we have seen that roughly 80% of women, even if they at start of pregnancy, they come up with the 11 gram of hemoglobin. But if we don't give them iron supplementation and they don't take their diet properly, they become 9 gram at term, because the physiological need, hemoglobin fall of 2 gram percent is there because of fetal needs. The developing baby needs iron stores from her mother, so that is why the hemoglobin fall is there. At present, our diet is not rich in that level of iron store to build up the iron stores. So if anyone can make it up with the dietary advice that we have shown in one slide, they can make it up, then we don't need it iron supplementation. But because of its increased prevalence, we should start it for everyone.
Point well taken. And Dr. Suneet Kumar from Panchkula also thanking you for your talk. Other questions? We acknowledge the questions on diabetes and growth. We'll take them up shortly. But Dr. Gauri Shankar says, sir, in a routine OPD, person has diabetes, male, female, that is immaterial. At 8.5 gram, roughly what dosage of ferrous fumarate should I give?
For 8.5 gram of hemoglobin. So that is the deficiency level. So we should start her with 100 milligram. If we should start him with 100 milligram, and we will see after 3 weeks, 2 to 3 weeks, we will see if hemoglobin rise is there. It is maintaining. That's all. Because for oral iron, we don't need to calculate the dose. That is for injectable iron. If we are talking about the dosage, so we have to see the response. If response is there with the 100 milligram, we don't need to increase the dose. Otherwise, we can increase the dose, double the dose.
And Dr. Gauri Shankar continues, supposing we decide to give ferric carboxymaltose, then how many doses? 1, 2, 3. What is the most common in your OPD?
For pregnant women, we give 500 milligram, means just 10 ml. And for other patients, because that depends upon her hemoglobin level. For other patients, if they are willing to take, because we get their serum iron levels, if iron levels are very low, we give them 1 gram, because the maximum dose is 1 gram in one sitting. Otherwise, we can repeat it after 1 or 2 weeks as per need. 500 milligram in 2 doses.
And we also have to remember, of course, not from obstetric point of view, anemia is a clinical condition, that is a clinical diagnosis. There are many causes. The commonest is iron deficiency. So that is one thing we should be aware of. And we should also be aware that iron deficiency may present with other things. Last week, Dr. Kamal Sharma spoke to us about heart failure. Iron deficiency may not necessarily present with a low hemoglobin. It can present otherwise as well. Dr. Gauri Shankar says, supposing patient is allergic to iron sucrose and hemoglobin is 7 gram, then how do we decide between blood transfusion and FCM?
See, FCM allergic reactions, it's not if someone is allergic to sucrose, that person will be allergic to FCM. So we can give them FCM with all the arrangement to check for the anaphylaxis, because we give in those cases we use just one ampule, the one vial, that is a 10 ml vial, and we start it very slowly. It's not we have to give it in 15 minutes. We start with the same speed to maintain it 15 minutes. We give very slow. If patient tolerates it well, there is no feature of anaphylaxis, then we can increase the dose and finish it in 15 minutes.
And if initial hemoglobin is 7, patient has 8 months of pregnancy, then of course you will give iron. You can give iron sucrose if that is available. But when do we recheck hemoglobin? Just 1 month left for delivery.
See, if we give injectable iron, we can recheck it. Earliest is written as the five days, but minimum we take 1 week. but routinely we check it after 2 weeks because patient gives the feeling of well-being. That is the first thing we get from the patient. Maximum patients say that our quality of life has improved after taking IV iron injection. So that is the response.
This is actually similar to what we do in diabetes practice also. We tell them that the anabolic effect of insulin will come first and the glucose lowering effect will come later. So when we are counseling our patients, it is a good idea to give them a reality check. Within 4 to 5 days, you will begin to feel better. You will get a psychological kick, maybe a physical improvement, and then the hemoglobin will improve on its own. Like the glucose level also, depending upon the insulin that you are giving, you will tell them that fasting will come down first or postprandial. Also, Dr. Bharti, greetings to you from Dr. Pradeep Rawal from Ujjain in Madhya Pradesh. And many other names are there. Let us take some other uh, questions. So, Dr. Khuzima Merchant from Mumbai says, could you repeat the formula to calculate the dose of injectable iron, please?
See, for adult, we take is 15 gram minus the hemoglobin level, means HB deficit into weight into 2.4 plus 500 milligram for the that the iron stores.
So, HB deficit with an ideal of 15.
Yes.
So, let us say the HB is 10. So, 15 minus 5, minus 10 is equal to 5 multiplied by body weight multiplied by 2.4. So, supposing the lady is, let us say, 50 kg heavy. So, 5 into 50, 250 multiplied by 2.4, which would be roughly 600, 650 plus 500. So, that actually crosses 1,000 milligram.
So, in single go, we have to give maximum of 1 gram. So that
Not
is
more
it.
than.
That is for FCM. But for sucrose, the single dose is of 200 milligram. Per week, we can give up to 600 milligram. So if our requirement is more, so we have to continue. We can give it alternate day, we can give it twice a week, or we can give it weekly, depending upon patient's convenience and ability to visit hospital.
Sucrose. And Dr. Khuzima continues with the question. She says, if I have given IV iron, I calculated the dose, I give the full dose. Then after that, do I need to give oral iron or can we skip it?
We can start it. We can start it. If full dose is given, then it's not needed. But if some deficit is there and her hemoglobin rises not there, we can give her oral iron. Usually in pregnancy, we give 500 milligram. Practically what I am doing, giving 500 milligram. Kick is there, her hemoglobin starts rising. Then we supplement her with the oral iron. So by the time she reaches delivery time, because if give FCM is costly. So sometimes patient don't afford it. If needed, we can repeat the dose, or otherwise practically we give oral iron followed by it, following the injection. After 2 weeks, we start it.
Dr. Nitin Narula has a question. So in thalassemia, there is actually no point in giving iron unless the patient has iron deficiency also.
Along with it, yes.
Yeah. So in thalassemia minor, the hemoglobin will always remain on the lower side. There is nothing that can be done to improve it. Neither do we need to improve it. Many other questions coming up. Dr. Meena asks you, in your practice, when do you prescribe iron? Breakfast, lunch, dinner, before meal, after meal? And so can you give a general answer and then specifically talk about people who are also taking medication for thyroid or for calcium?
Yes, in routine, I prescribe at bedtime or with the dinner, because at bedtime the absorption is better of iron preparations. And if she is taking thyroid medicine, with that also it's advisable to give it at bedtime, because minimum of 8 hours gap should be there from the thyroid medicine.
One more question coming from Dr. Meena. Which is the best salt? Just from a side effect point of view, which is the best? And from maybe a cost point of view, which is your favorite?
See, from cost point of view, ferrous fumarate. Otherwise, if we want to take it free, ferrous sulfate is freely available with the government. So free means cost free. And in practice, cost effective is ferrous fumarate. And if from side effect point of view, ferrous pyrophosphate is good. That is in nanotechnology. It is costly, but gives good results, minimum GI side effects. Usually patients complain of GI side effects. So that is not there with the pyrophosphate.
With the lysosomal or microsomal iron, the other advantage is, of course, all the iron is absorbed. So the absorption is much better because it is a nanoparticle. Second thing is there is no black stool. So many times you will see patients coming and arguing, fighting that you gave me this medicine and it caused piles. So where did the piles come from? Actually, it is the dark colored stool which they think is bleeding per rectum, and then they pick up a hue and cry about it because that is a common diagnosis in general practice. So if you want to avoid that, then also it is a good idea to give the microsomal iron. It will not cause black stools.
So to such patients, I tell them that is a proof that you are taking iron.
Mm,
So
that the
if
medicine is
you are
actually
taking
acting.
it,
Yeah.
yeah, that is a test that you are taking iron.
So let me take a few questions on diabetes from Dr. Vilas Sonavane. He had discussed a case last time who was on Novomix twice a day and metformin glimepiride twice a day. Then he shifted to Novorapid 3 times a day. Daytime control is very good now. Glargine 20 units at night. Still the fasting is 140 to 180. Already the oral therapy is optimized. Dapagliflozin, sitagliptin, metformin. We cannot do better than that. So, and still fasting glucose is high. So, how we explain to the patient is, so these are the exact words I use. जो दिन की शुगर है उसका दिनचर्या से लिंक है. Your daytime sugar is linked to your daytime lifestyle. आपकी दिनचर्या सात्विक है. Your lifestyle is balanced. That is why your daytime glucose is balanced. So thank you very much. So this is how we begin. You are doing a great job. We thank you for whatever you're doing. If the wife or the husband is accompanying the patient, we thank them as well. Thank you for cooking tasty food for our patient. Thank you for keeping a very happy atmosphere at home. That is why his daytime sugar is normal. But now the fasting glucose comes from the liver. We do not have too much of control over it. This is what we say. Actually, if the patient is not sleeping properly, the patient is a shift worker, the patient takes a lot of alcohol at night, then fasting sugars will rise. That is also linked with lifestyle. What we can do for this particular patient is you might want to reduce the Novorapid from 10 to 8 units. So you save 6 units there. Those 6 units you can add to Glargine. So 20 becomes 26. That is one option, the cheapest. Second option is you can change Glargine U100 to Glargine U300 or to Degludec, which are ultra long acting insulins. And this will help improve the fasting glucose. Third thing you may wish to do if you take a good history, after taking a good history, you might want to add a very light dose of anxiolytic or sedative. It can be alprazolam or clonazepam, but that is addictive. You might want to add a sleep-inducing drug like zolpidem or lemborexant, which actually works very well in diabetes. So these are some options we can do. From a dietary perspective, you can say just please reduce 1 or 2 idlis or 1 or 2 chapatis at night, but do not go hungry. You change that chapati to a protein-rich food, maybe to dal or to meat or to an egg. So do eat something in place. Another case shared by Dr. Vinay Desai, 8-year-old girl who has growth retardation, weight is 15 kg only, and height is 90 centimeter. So first of all, nutrition. The first test to be done would be an X-ray bone age. This will tell you about the bone age. If the bones are 8 years old, then chances of nutritional deficiency are more. Chances of endocrine deficiency are minimal. But if the bone age is retarded, maybe it is 6 years, as an example, then the chances of endocrine deficiency are high. And the first test we will look for is the first disease we will look for is panhypopituitarism. So the test will be T3, T4, TSH. For growth hormone, we need to do a stimulated growth hormone. So please do not do yourself. It would be a good idea to refer to the endocrinologist. But T3, T4, TSH should be done. You can also do a TTG for celiac disease to screen for celiac disease. These will be the two common diseases. If bone age is normal, then do think in terms of nutritional deficiency. It might turn out to be iron deficiency for all you know. Another question from Dr. Vinay Desai. Patient is very well controlled on 12 units rapid 3 times a day and basal 30 at night. So total is 36 and 30, 66. We can shift actually to premixed. 66 you change to 60. So you give Novomix 30 in the morning and 30 with dinner. That 30 should be fine. 30 Novomix will contain 10 units of Novorapid. It should cover the postprandial sugars. At lunch, you may wish to add maybe acarbose. That is what I will add, acarbose plus metformin. Or you can add repaglinide plus metformin. The most economical drug to add at lunchtime will be glipizide plus metformin, 1 rupee tablet. but there is a risk of late night hypoglycemia with that if you're giving along with insulin. So the dose calculation total was 66. You just, for convenience, made it 60. It is easier to up titrate later, but it is not a good idea to cause hypoglycemia immediately. And it is good to see so many patients actually getting better because of iron talks. So thank you so much, everybody, for all your questions, and especially Dr. Vinay and Dr. Vilas, Dr. Merchant. Thank you for the follow-up that you share with us. It makes us feel part of the family. And Dr. Meena, thanks is to you for asking the questions and making us feel part of the family. So, with this, we've come to the end of today's questions. Dr. Bharti, I'd like to thank you once again for your time, your expertise. Sometimes, those of us who are not handling pregnancy, we tend to feel afraid because we are worried about drug interactions, we are worried about other things in pregnancy. So, could you just repeat, is there any chance of iron being mitogenic, of iron being teratogenic? If, as a non gynecologist, I see a person who is planning pregnancy, what advice should I give her from an iron point of view, anemia point of view?
Mm, that is not that is not a teratogenic or mitogenic. We should, because if she is anemic before planning pregnancy, we should improve her hemoglobin level. Because if she starts her pregnancy at ideal hemoglobin level, the chances are that her outcome of the pregnancy will be good. So, in general, but some I'm not. You just answer about this, so I'm not comfortable.
If we are, if we
She
are, mm,
about the mitogenicity. So,
mm. But if we are handling anyone who is planning a pregnancy in future, I think it is every physician's responsibility to make sure that her hemoglobin is normal. And we should do that before the pregnancy starts, ideally. We should not wait for pregnancy to occur and then we begin treating anemia. And if the patient is on any tablet, whether it is iron or calcium, and she gets a UPT positive, we should counsel her to go to the gynecologist immediately as soon as the UPT becomes positive. But it's been great having you on the show, Dr. Bharti. A lot of people listening from across the country, and your take home message for everyone. Our topic today was iron and pregnancy.
see, in general, every woman or every person needs iron in their diet, or if diet is not sufficient, they need with the supplementation. And this is especially so for the pregnancy because we have discussed for a long that iron should be given. So for every patient, we should take just 5 minutes from our busy OPD. We should tell them about the nutritional advice as well as the iron supplement, because if we tell them the benefits of taking iron during pregnancy to for themselves and for their developing fetus or baby. Sometimes the patient comes that my hair length is increasing, there is no fall of hair, and after delivery my hair are falling. So sometimes their hair fall is increases. So if you tell them that if you take iron supplementation, there are chances that your hair fall will reduce. So if we counsel them for themselves as well as for the fetus, and if the iron supplementation taken during pregnancy, that will show the transgenerational effects. The IQ of their baby will increase. So in that case, they will take it. So just 1 or 2 minutes extra spent on per patient, that will benefit the whole of the society. So that is my take home for the all the doctors, those who are gynecologists or non-gynecologists also. They should be sensitized that iron supplementation should be given during pregnancy.
Thank you for those comments. And with this, I'd like to hand over back to Team FDC. Uh, Team FDC, 1 minute extra has such an impact on society, on the nation. And you have been giving us so much of your time. So thank you for that from all of us
Yes,
and
sir.
all
In
of you.
fact, this is for the first time we got both Dr. Sanjay as well as Dr. Bharti Kalra in our Diabetic Essential. Now it is been running the show of RN Talks. And thank you, Dr. Bharti, for taking us such a comprehensive guideline-based presentation today. And at the same time, Dr. Sanjay Kalra taking all the follow-up questions, which, for last so many weeks, all the doctors who have been following Dr. Sanjay for last 2 years now still asking the questions on diabetes. It's nice to see that, and they are eagerly waiting. for iron talks as well as for diabetes. Such a wonderful combination. We have gynecological orientation today, and in few episodes coming, we have another options of iron talks, which will be covering not only the heart, the cancers, and diabetes. Everything will be coming up so that we comprehensively complete the 360-degree of iron talks. And thank you, Dr. Sanjay Kalra, once again for bringing it into shape that we wanted to go and complete the 360-degree of iron talks. With this, I thank Dr. Sanjay and Dr. Bharti Kalra for giving their time. Both are actually from two different locations, and we completing from Bombay. With this, Jai Hind, good night.
Jai Hind.